Welcome. This is the first part of a two-part series on control of breathing. This part will center on carbon dioxide. Many factors, including anxiety, pain, exercise, and mechanical receptors in the lung and chest wall, have an impact on ventilation. For our purposes, however, the primary considerations are the impact of oxygen and carbon dioxide on the control of breathing. This content is normally presented in one of two ways, either a discussion centered on the anatomic structures or a discussion centered on the stimuli. Preferring physiology to anatomy, my presentations focus on the role of oxygen and carbon dioxide in the influencing respiratory drive. In keeping with my philosophy that presentation should be limited to 15 to 20 minutes in duration, this material on control of breathing is presented in two parts. The first focusing on carbon dioxide, the second focusing on oxygen. Although the emphasis of this presentation will be on the chemical stimuli to ventilation, it is appropriate to spend 2 or 3 minutes presenting the anatomy related to the central control of breathing. The medulla is the site of that part of the central nervous system that is involved with the control of breathing. Central chemoreceptors are located in the retrotrapezoid nucleus of the medulla. This illustration shows the location of the dorsal and ventral respiratory groups, the concentrations of neurons primarily involved in controlling ventilation. It is important to recognize that both the dorsal and ventral respiratory groups are bilateral. In this illustration, one group is shown on each side for the purpose of clarity. The dorsal respiratory group is the source of the timing of the ventilatory cycle and is composed primarily of inspiratory neurons. In the ventral respiratory group, the more caudal neurons are primarily concerned with expiratory function. The more rostral aspects of the ventral respiratory group are primarily involved with innervation of the airway and are responsible for airway dilation via the larynx, pharynx, and tongue. This illustration demonstrates more accurately the bilateral nature of these structures. The only things that are important to us, and even then the importances of marginal significance, are 1. The chemosensitive neurons are located in the median raphe and arcuate nuclei, and 2. That the prebotzinger complex is thought to be the rhythm-generating center for respiratory control. As previously noted, the rostral-ventral respiratory group consists primarily of inspiratory neurons, and the caudal-ventral respiratory group consists primarily of expiratory neurons. This illustration demonstrates the relationship between neuronal and muscular activity. One of the aspects of ventilation that is not commonly appreciated is that during early inspiration, neuronal activity increases tone in the pharyngeal dilator muscles, resulting in an increase in the diameter of the supraglottic airway. That aspect of ventilation is demonstrated here by showing the firing of the neurons in the early inspiratory group and the associated activity of the airway adductors. Now for the physiology. Carbon dioxide is produced within the cells as a result of metabolism. The CO2 diffuses from the cell into the capillary blood. In the blood, some of the CO2 remains dissolved and represents the partial pressure of carbon dioxide in venous blood. Under normal circumstances, the partial pressure of carbon dioxide in venous blood is about 5 to 10 millimeters of mercury greater than that in arterial blood. Approximately 90% of the CO2 diffuses into the red blood cell. About 1/3 of the carbon dioxide in the red blood cell binds to proteins, the largest portion of which is bound to hemoglobin to form carbaminohemoglobin. The remaining 2/3 of the CO2 that diffuses into the red blood cell is dissolved in water, a reaction catalyzed by carbonic anhydrase, to form carbonic acid, H2CO3, not shown in this illustration. The carbonic acid dissociates to hydrogen ion and bicarbonate. The bicarbonate diffuses from the red blood cell into the plasma. At the lung, the processes are reversed. The carbon dioxide in plasma diffuses into the alveolus, resulting in a decrease in the partial pressure of CO2 in the plasma, which results in diffusion of carbon dioxide from the red blood cell into the plasma. As the partial pressure of carbon dioxide in the red blood cell decreases, the chemical reaction that produced carbonic acid and bicarbonate reverses, resulting in more dissolved CO2 in the red blood cell, which diffuses into the plasma and from there into the alveolus. Furthermore, the carbon dioxide that had been bound to hemoglobin is released from the carbaminohemoglobin, resulting in more dissolved CO2, which diffuses into the plasma. The CO2 dissolved in the plasma diffuses into the alveolus for elimination via ventilation. The previously described central chemoreceptors work in conjunction with peripheral chemoreceptors, located primarily in the carotid bodies, to attempt to maintain normal values for oxygen and carbon dioxide in the face of changing conditions. Although the carotid bodies are the primary drivers of the respiratory response to hypoxia, they also respond to changes in the partial pressure of carbon dioxide and to alterations in pH. The peripheral chemoreceptors stimulate an increase in minute ventilation in response to a decrease in the partial pressure of oxygen, an increase in the partial pressure of carbon dioxide, or an increase of hydrogen ion concentration in arterial blood. While the central chemoreceptors do not respond to changes in PCO2 as rapidly as the peripheral chemoreceptors, the central chemoreceptors are responsible for about 85% of the increase in minute ventilation occurring in response to hypercarbia. If an increase in CO2 production occurs, for example due to an increase in body temperature, in the short term there will be an increase in the partial pressure of carbon dioxide in arterial blood. The CO2 diffuses across the blood-brain barrier, which is permeable to carbon dioxide but not hydrogen ions. The result is a comparable increase in the partial pressure of carbon dioxide in extracellular fluid, cerebrospinal fluid, and the cerebral tissues. This results in an increase in CSF hydrogen ion concentration. The increased hydrogen ion stimulates the central chemoreceptors. Stimulation of the central chemoreceptors results in an increase in ventilation. It should be noted that, if the partial pressure of carbon dioxide remains elevated for a long period of time, over the course of many days or hours, the CSF pH gradually returns to normal as a result of an increase in the bicarbonate concentration. This change is responsible for the development of chronic hypercapnia in patients with lung disease. Respiratory drive is most commonly assessed using the CO2 response curve. I'm going to spend a significant amount of time on this, not only because it is commonly used as a basis for questions on exams, but also because understanding the CO2 response curve is important in understanding why patients respond the way they do during anesthesia and specifically upon emergence at the end of an anesthetic. First, notice the axes. The x-axis is the partial pressure of carbon dioxide in arterial blood. The y-axis is minute volume. The dotted line indicates the arterial CO2 that occurs as a result of varying conditions, assuming no inspired carbon dioxide or increase in dead space. For example, the curve predicts that if minute ventilation is increased to 10 liters per minute, the arterial CO2 would be in the low 30s. Generally speaking, the CO2 response curve is linear over the range that it is usually studied. With spontaneous hyperventilation, to achieve a level of arterial CO2 below the resting level, some patients will continue to ventilate at an essentially unchanged minute ventilation, as shown by the horizontal extension of the line. Other patients who spontaneously hyperventilate will develop decreased minute ventilation with decreasing arterial partial pressure of carbon dioxide to the point where they eventually become apneic, as represented by the dotted line. The PCO2 at which this occurs is known as the apneic threshold. Because it is a straight line, it can be described based on the slope of the line and the point where the line intercepts the x-axis. If S is the slope of the line and B is the intercept of the line with the x-axis, that is, the apneic threshold, the line can be described by the formula in red on this slide. It must be appreciated that each patient may have a slightly different CO2 response curve. Further, there are diurnal variations in the curve for a given individual. If there is so much variability in the CO2 response curve, how is it useful? One use is to document the effects clinical conditions have on respiratory drive. This comparison demonstrates that metabolic acidosis causes the CO2 response curve to shift to the left. This is documented by a decrease in the apneic threshold. The curve is also used as a research tool to describe the respiratory effects of different drugs. Although this graph illustrates the concept, it is of dubious accuracy. The content of this slide is more accurate than the prior graph and is a common source of exam questions. The questions can be framed by asking which class of drugs produces an isolated decrease in the slope of the CO2 response curve, or an increase in the apneic threshold. Pause the presentation to make certain you understand how each class of drugs alters the CO2 response curve. In summary, the central chemoreceptors are located in the medulla. Although the partial pressure of carbon dioxide in arterial blood is a primary stimulant for central chemoreceptors, only about 10% of the carbon dioxide in venous blood is dissolved. Peripheral chemoreceptors respond within seconds to changes in the partial pressure of carbon dioxide in arterial blood. The blood-brain barrier is permeable to dissolved carbon dioxide, but not hydrogen ion. Despite that, ultimately it is a change in hydrogen ion concentration that stimulates the central chemoreceptors. The CO2 response curve, which is linear, is used to assess the impact of drugs and conditions on respiratory drive. This is the end of this presentation on the effect of carbon dioxide on the control of breathing. There is another presentation on the impact of oxygen on respiratory control.